Thanks very much. Good morning. First, some acknowledgements. I'd like to acknowledge the team of wonderful colleagues that I work with, not just the staff, but also we have a strong ethos of involving families of disabled children in all aspects of our work. And it's nice to see Julia and perhaps others there. I'd like to, of course, thank Cerebra for ongoing support of our research group and recognise that. And also the support we get from an organisation called PenCRU, which enables us to work with methodological experts and colleagues such as Siobhan, who you'll hear from in the next talk. Expertise that comes from outside our group. You can read more about our programme of work on our website, and as Chris mentioned, you can see some examples of how we actually seek to involve families in our work in a meaningful fashion on the display area. So I would encourage you to try and push past the first coffee stand to the upper one and come and find out about what us and the other research groups are working on. Now, our research group seeks to evaluate ways to improve the health and well-being of disabled children and their families broadly. So naturally, we're interested in whether we can measure health and well-being outcomes. Now, not that measurement is the only way to explore health and well-being. As you'll hear in Siobhan's talk, we're also interested in qualitative approaches. But measurement offers a very powerful way to try and assess whether treatments work and whether services are effective. So as an overview, I'm going to introduce you to some ideas of what health and well-being might be. I'm going to talk about something called patient-reported outcome measures, which have been alluded to in the earlier presentations to some extent. I'm going to talk about why PROMs, patient-reported outcome measures, are becoming very important in terms of health policy. And I'm going to describe in the process some of the work that we're carrying out in this area. So without wanting to frighten you with a diagram, this is the way the World Health Organization currently conceptualizes health. This model replaced a previous model whereby handicap was somehow an inevitable consequence of impairment and disability in a very one-directional process. You'll notice that in this diagram the terms tend to be more positive, and that many of the arrows go in two directions, recognising a much more bidirectional relationship between the components of health. So if we explore first body functions and structures, these are really the organs and basic processes of the body, many of which we'll take for granted until something goes wrong with them. So here you see these basic organ and physiological processes that allow us to function at a basic sense. So quite separately to those basic processes are activities and participation. Now these describe day-to-day tasks and life situations that we would be involved in that are universally held to be important parts of a healthy life. So similarly, these are listed. Okay, so the World Health Organization provides a combined list of activities and participation. One of the problems with it is they don't separate the two terms despite defining them differently. But they do provide a list of chapters of types of activities and participation that are held to be important for children. So a person's functioning in each of those domains is not just a facet of the body itself, it's also now recognised that there's a social context to that, and environmental factors play a part, such as not just the proximal physical environment, but also social environment that families encounter, both in the community but also from a policy perspective. So there's a very broad conceptualization of environmental factors that affect health, and also personal factors, which are the more fixed factors such as age, sex and gender. Now, quite separate to the World Health Organization's definitions of health is a definition of quality of life, which is a very problematic term in many respects because it's defined differently by different people for different purposes. For me, it's synonymous with well-being. It's how someone feels about their life. And in terms of health-related quality of life, how they feel about their ability to function in those domains rather than the level of functioning itself. I'm just going to shift now and talk about patient-reported outcome measures, which have been described as tools in previous studies. Now, these are measures that are patient-reported, self-evidently, but if the person can't report themselves, if they're too young or they don't want to or they're not able to, then it can be done by a proxy person, such as a parent for a child. The outcome is a snapshot of how that person's life is in a previous day, week or month. It has to be a time period that's possible to be captured, to be possible for the respondent to recall accurately. And the measure is a questionnaire that someone completes, perhaps somewhat simplistically. It has an underlying scoring system, and you've seen these deployed in the studies that people have described about stress earlier this morning. But stepping back from the single domain, patient-reported outcome measures are used to measure aspects of health and quality of life, predominantly across groups and more rarely with individuals. So for those that might be unfamiliar, the respondent completes the questionnaire based on the ratings and replies to the questions. A score is applied, such as 0 to 4, from rarely to all the time, how often someone does something. The individual question responses are added together to provide a domain scale score. And then there's various bits of statistical noodling that are carried out to ensure that the scales are robust in terms of they are measuring a single construct. And that measure's valid and reliable. One area where that's not the end of it is in the measurement of health utilities for health economics, whereby it's not just the respondent's view that's counted in the score, it's also a societal preference for that particular health state. And the importance of measuring, the reason for mentioning that is the increasing importance of cost-effectiveness studies as to whether treatments are provided. And so it's important to understand that the person, that's not a true patient-reported outcome measure. The patient report is only one half of it. The other half is how people sampled as a representation of society would feel about being in that health state, and speaks to people's understanding or lack of understanding about those health states. So what outcomes are measured? There's a whole variety. There's health status, which is more akin to body functions and structures that I alluded to earlier. There are measures that are called generic, that is, they can be used with anybody, as opposed to condition-specific measures, which are specifically for people with a particular condition that cover issues that wouldn't be covered in sufficient detail in the generic measures. There's multidimensional measures where the measurement covers a handful of different constructs within the same scale, as opposed to single-dimension, unidimensional scales, such as those used to measure, for instance, stress or mobility or behaviour. So some measures capture more than one construct. Now, some work I did in Oxford for the Department of Health looked at the feasibility of routinely using patient-reported outcome measures in the NHS. And from reviewing the available evidence, it's possible to conclude that Many children from the age of 8 and above can report their health in a reliable fashion using these scoring systems. Some children can do it younger, and some children will struggle to do it at any time. It's not chronologically determined, more developmental. The use of these questionnaires is considered ethical, subject to their usually parent consent for completing the forms, and some checks to check that there aren't any suspicious indicators that would cause concern about the health of the well-being of the child in terms of child protection issues. Now, whilst I've said that parents or carers can provide proxy reports, it's important to remember that they have a different perspective, and so they have to be analysed in a separate way. Now, that's the background. Here's the meat. This is some findings from a large European study of cerebral palsy, looking at children's participation and quality of life. So 2 different constructs. And this was hundreds of children across 6 different European studies conducted by Alan Culver and the Surveillance of Cerebral Palsy in Europe group. Now, they found that children with cerebral palsy participated in the way that's defined by the World Health Organization less than other children. They also found that participation was substantially affected by pain and was strongly associated with the severity of the child's cerebral palsy and their associated impairments. Whereas in contrast, how children felt about their lives, how they felt about their health, showed largely the same findings as the children across Europe, even within each of the countries where it was measured. So a distinction can be made between what's being measured, children's functioning or how they feel about their functioning. Now, that's not to say that there aren't some children who don't feel so good and some children who are really quite delighted, but the distribution of quality of life in children with cerebral palsy in a very representative sample was found to be similar to the regular population. And that's something that's been picked up before and called the term the disability paradox, great quality of life against all odds. Our presumptions, societal understanding of what it might be like to be in a certain health state at a certain level of functioning isn't always substantiated by how people themselves feel about their lives. Now, there are some subdomains in this measure of quality of life, and there are some caveats in what I'm saying. But the message is, it depends what you measure, and it depends who's providing the data for that measurement. The person themselves can be a very powerful respondent. Now, just move on to try and emphasise the importance of patient-reported outcomes and their emergence as powerful tools in the health services across around the world. The Food and Drug Administration in the United States is the body that provides licensing for drugs and other interventions, and they now require patient-reported outcome measures to be part of any evaluation. Similarly, the National Institute for Clinical Excellence in the UK also require this sort of evidence as some demonstration that treatments are beneficial from the patient's perspective. The other area where we're seeing PROMs take a prime place is in the NHS outcomes framework, which is what under the new systems will be used to hold those who commission services to account. This is really quite a profound power that will be given to PROMs, and we hope they're robust enough for the task. Now, in quite separate work, Sir Ian Kennedy produced a report a couple of years ago that talked about overcoming cultural barriers in the NHS. It was about the efficiency of children's services to produce health for children. And one of the major barriers they described, or Ian describes, is that there isn't a common vision about what the NHS is trying to do for disabled children. And he recommended that there be some work done to bring the views of children and families and those of professionals together to provide some aim and ambition for what we were all trying to achieve. So having read these two reports gave us an idea. And that's why we came up with a study that became known as the Children's Outcome Measurement Study, or CHUMS. And this was work to inform the NHS outcomes framework, to think about what outcomes should be measured for children with neurodisability, which is an umbrella term for impairments of neurological origin. So I can tell you about this study. I should say it was funded by the National Institute for Health Research, but we signed contracts to say we're not representing their views or those of the Department of Health. We assembled a very strong team from around the country, from different institutions, all brought different skills, and we're all ably kept on course by Dr. Astrid Jensen's. Now, there's three parts to this work. First, there's a systematic review. That's where we look across everything that's been published in the literature and bring it all together in a systematic way in one place. And through that, we've tried to identify any candidate generic patient-reported outcome measure that could be used for children. We've then systematically going to appraise evidence of how well those PROMs perform in terms of reliability, validity, how much they can measure change, how accurate their measurement is. As I say, there's a great preeminence of patient-reported outcome measures as powerful tools, and it's important for us to be extremely critical at how accurate those measurements are, at what they say they're measuring, and whether they can do that in a reliable way. There's also issues about acceptability and feasibility, how practical they are, how long they take to complete. And in terms of what they're measuring, we'll look at the World Health Organization's definitions and classification of body functions and structures and activities and participation to look exactly at what the measures are assessing. We're also going to gather children and parents' views, interviews and focus groups with young people and separately with other parents. And that will help us to understand exactly what young people and parents want the NHS to produce for them in terms of their child's health. And this isn't an easy thing for families to grasp, and so it's one area where families working with us in our family faculty have been very helpful in helping us to fine-tune the ways in which we ask the questions to try and keep people on topic. And we have a systematic way of analysing that data called the framework approach. Now, we're also gathering health professionals' perspectives through an online survey and asking them to come together as a diverse group of clinicians from a range of professions around the country. What is it they do? What are their treatment objectives when they see children? Other than, you know, the supporting the family is self-evident, but what is it that we might be able to measure in terms of improving children's health? And in the analysis of that and the qualities of work with families, we bring it all together. We try and synthesize it into one place. The three streams of work are running fairly concurrently, and will come together in a consensus meeting next March. So I hope that I'll be able to bring those findings to you at the Cerebra conference perhaps next year. The takeaway message is, I want you to think clearly about what exactly is being measured in terms of health and well-being outcomes, and be critical about it. The measures must be selected carefully and they must be fit for purpose. When you see someone's measured something, you should not take it at face value. You should really think critically and ask them what evidence is there that that measurement is accurate. What's its reliability? These are fundamental questions you should be asking, particularly when those measurements can be used to profoundly influence health policy. In terms of using them with children and young people, it's extremely feasible and possible, and it should be children's right to have the opportunity to complete these measurements, for them to self-report their health whenever possible. Patient-reported outcome measures are incredibly powerful now, and that's unlikely to diminish in the future. The science is moving forward. There are changes in the way the measurement properties can be assessed, and we're trying to take advantage of that to ensure that children's health is assessed in a proper and appropriate way. Thank you.